Are the slides visible?
Yes, sir.
Okay. So as we have been doing in the last 2 days, so this session will be the OSCE for the biostatistics and palliative care. We appreciate all your answers in the chat box and also the questions in chat box. For the betterment of this session going ahead smoothly, I'll request you to enter your queries and answers in the chat box so that we don't get disturbed during the presentation. Okay. So the first question, Dr. Ankita.
Yes, sir.
Hello. What is incidence?
So the
Define incidence.
incidence is the number of the new case of a specific disease in a defined population in a given period of time.
Okay. So next, what is prevalence?
Prevalence is both the old and the new case existing at that point of time in a specific population.
Okay. So are there any two types of prevalences? You know.
There are mainly two types, sir. One is point prevalence and another one is period prevalence.
Okay. So what is the basic difference between? Is there any difference between incidence and prevalence?
Incidence, we calculate only the new cases, but the prevalence, we can calculate both the old and the new cases.
Okay. The incidences is usually the all the new cases in a specific disease defined in a specific period of time. Okay.
Yes,
But
yes,
in prevalence, it is the current cases, both old and new cases. It can be defined at a point in time or period of time. Okay.
yes, sir.
Okay. Now coming to next question, what is relative risk?
Relative risk is a ratio of the incidence of a disease among exposed and the non-exposed group.
Okay. And what is odds ratio?
Odds ratio is a measure of strength of the association between the exposure and the outcome.
Okay. In this case, as you can see, what if there is odds ratio of more than 1? So what does it signify?
So odds ratio we calculate in a case control study, and if it is more than 1, it means there is a increased risk of the outcome in the exposed group than the non-exposed group.
Okay. So can you name a matlab, do you have a second name for the odds ratio? Is there any other name?
Cross product ratio, sir.
Yes, it's a cross product ratio. So is there a difference between relative risk and odds ratio? In which cases do we use the relative risk, and in which cases can we use the odds ratio?
In the for the case control study we do the odds ratio, and in the cohort study we do the relative risk ratio, relative risk.
Okay, very fine. So we'll be moving to third question.
Yes.
Okay, as you can see here, the
left. Dr. Ajitesh.
Yes, sir.
Can you put in the slideshow view?
I think it is in the slideshow view.
No, sir, it's not in slideshow.
Not in the slideshow view. Okay, right. Now it is correct.
Okay, okay. Okay, in this third question, can you define the sensitivity of a test?
Sensitivity means that the ability of a test to identify those who correctly have the disease. Like in this box, the sensitivity will be true positive by true positive plus false negative.
Okay. And what about specificity?
Specificity means the ability of a test to identify those who do not have the disease. Like true negative by true negative plus false positive here.
Okay. So if we have a patient, say like 90% specificity, so it means that 90% of the non-disease person screened by the test will have the negative result. Okay?
Yes.
Okay. And what about positive predictive value?
PPV is defined as a probability that the patient with positive result have the disease.
Okay. So what is this? What does it signify? If there is more prevalent disease, so what will be the
PPV will be more PPV will be there, sir.
Yes, PPV will
more
be more
prevalent the disease, more PPV.
Okay. So and the last is what is negative predictive value?
It means that the person with negative result do not have the disease.
Okay. Now, next question, can you identify this figure?
This is a box and whisker plot, sir.
Okay. Can you explain this figure?
So there is a lower quartile. That means that the lower value of the 25% of the lower value will be below the lower quartile, and there is
Yes.
a upper quartile, which means that 25% of the upper value will be above the upper quartile.
Okay. So basically, we have this in the midline. We have the median value, and on
Median,
either side of the box, we have upper quartile and lower quartile, and from beyond the box, we have two lines extending on either side.
Yes, sir. Lower
The
extreme.
whisker. Okay. Extending the upper extreme and the lower extreme. Okay. So what is the significance of this box and whisker plot?
Sir, it shows the spread and the skewness of the data throughout their through their quartiles.
Okay, fine. So next question. Can you identify this image? What is this image?
It's a waterfall plot.
Okay. So when do you use the waterfall plot?
To check the individual patient's response to a particular drug or therapy.
Okay. So when you're going ahead with a particular drug treatment, so we use this plot to describe the how each individual patient will behave, or how they are responding to a particular drug or treatment. Okay.
Yes, sir.
Okay. The next question, that is, can you identify this diagram or figure?
This is a dot plot, sir.
Okay. The dot plot, or is also called as dot
Dot
chart.
Yes.
So does it have any significance in oncology practice?
It has a significance in hemato-oncology, sir. It helps in finding the blast population, helps in making the diagnosis for the detection of the minimal residual disease, and also the immunophenotype.
Also, yes. Basically, it is used in case of both the diagnostic and therapeutic purpose in case of hematological and hematolymphoid malignancies. It helps in diagnosis, as you rightly said, for the immunophenotyping and finding the blast population. And for the response treatment, it is used in case of detecting the minimal residual disease.
Minimal residual disease.
And also, it can be used in cytogenetic and molecular abnormalities like DNA ploidy. Okay. So coming to the next question, how many phases of the clinical trial are there?
So there are 4 phases.
No. Usually it is
one it is preclinical, and then there are 4 phases.
Okay, from phase 0 or preclinical phase to phase 1 to 4. Okay.
Yes.
Can you describe each phase one by one? What is a phase 0 or a preclinical phase?
Phase 0 is preclinical phase, sir, which we do mainly in the lab or on the animal testing. Yes. And it checks the safety or the mechanism of action of a drug.
Okay. Now, so the preclinical phase is done in the animals or in the labs prior to testing it in the humans. Okay. To note the safety and mechanism action, and also the dosing.
Yes, sir.
What about the phase 1 trial?
Phase 1 is where we check the safety and the dosing of the drug, and we do it in a small population of patients, and we can also see the pharmacokinetics and the pharmacodynamics of a drug.
Okay. So in a phase 1 trial, it is done in small group of persons to note the safety and the dosing. Basically, it is used to determine the maximum tolerated dose of a drug. Okay.
Yes.
Then what about the phase 2 trial?
Then the phase 2 where we check the efficacy and the side effects. Phase 2 is done comparatively larger group of patients, and it also shows the toxicity profile of a drug.
Okay. And what about the phase 3 trial?
Phase 3 is where we confirm the efficacy and the safety, and it is done in a mainly large randomized control trials. And the endpoints are like mainly overall survival, disease-free survival, like this only.
Okay. So this phase 3 trial is basically confirmatory trial. Here, what we do is that we have let's say we have a standard of care treatment, and we compare the new treatment, new protocol with the standard of care. Okay. For example,
Yes.
in case of locally advanced CS cervix, the standard of care is concurrent chemo RT. Okay.
Yes.
Now,
Yes.
as per the might have heard about the Interlace trial. The Interlace trial is they are comparing this
Sensitive.
NST followed by CTRT versus this is for an example. I am
CTRT.
just elaborating this for an example. NST followed by CTRT versus CTRT.
CTRT.
So if you are comparing these two, means if you are comparing a new treatment protocol to a standard of care, then it's basically it comes under the phase 3 trial. Okay.
Yes. Yes.
After the phase 3 trial, if the drug is efficient enough, then the drug is marketed into the released into the market. Okay. So okay, next about the phase 4 trial.
Phase 4 trial was done after the drug is being marketed, sir, and it is mainly the post-marketing surveillance, and it
Yes.
shows the real-world data and also the long-term safety and the side effects of the drug.
Yes, rightly, you have rightly pointed out. It is basically done post-marketing, means after the drug is released into the market, and you have it is done for the to detect the long-term toxicity, and you can detect some rare toxicity. Okay.
Yes, sir.
Okay. Now coming to the next question, let's say you want to study whether tobacco causes lung cancer. So what will be your null hypothesis and what will be your alternative hypothesis here?
Null hypothesis states that there is no relationship between two variables. So in this case, my null hypothesis will be that the tobacco does not cause lung cancer.
Okay. And about
And the
alternative?
alternative hypothesis will be that tobacco causes the lung cancer.
Yes, you have rightly pointed out that the null hypothesis proposes that there is no, because prior to conducting a trial, we need to propose a null hypothesis and alternative hypothesis. Null hypothesis states that there is no relationship of the cause with the effect. Okay, so in this case, tobacco doesn't cause lung cancer will be a null hypothesis, and the alternative hypothesis just the opposite of null hypothesis, right? So in this case, the alternative hypothesis will be that tobacco causes lung cancer. Okay.
Yes.
Okay. Now coming to next question. Now we have a randomized control trial that compares CTRT with RT in locally advanced carcinoma cervix, and in this trial is reported p-value is 0.02, and the confidence 95% confidence interval for overall survival hazard ratio is 0.65 to 0.95. So do you think that this result is statistically significant?
Yes, sir. The p-value is less than 0.05 and the 95% confidence interval also does not cross 1. So it is statistically significant.
Okay. So can you define p-value?
P-value is a probability value, sir.
Okay. So it's a probability of obtaining the observed results. Okay. If the null hypothesis is true.
Yes, sir.
Okay. So identify this image.
This is a Kaplan-Meier curve, sir, which shows the survival over time.
Okay. So where do you use the Kaplan-Meier curve?
Sir, in
Survival
randomized
analysis.
control trial.
For survival analysis. Okay.
Survival. Yes.
So this Kaplan-Meier curve is a stepwise. You can see the steps. The
Yes,
stepwise
sir.
graphical representation of survival over time. Okay, showing the probability that surviving from time to, of treatment initiation, from treatment initiation to endpoint.
Endpoint.
Okay, so what does this each step represent?
Each step represent an event, sir. It's maybe patient's death or any disease progression.
Okay, so how do you compare two such curves statistically?
By using the log rank test.
Okay, yeah, you use the log rank test to compare the two survival curves statistically.
Yes.
Okay. Okay, identify this image.
This is a forest plot, sir.
Okay, so where do you use the forest plot?
We used in a for representation of a meta-analysis.
Okay, so can you name all the components? Identify all the components.
So in left side we have a study group, sir, that are enlisted in the meta-analysis. where
Yes.
we can write the author name or the publication year.
Yes.
Then there is a graphical part where the horizontal green line is the confidence interval. The
Of each
shorter
study.
of each study, yes, the
Yes.
shorter lines mean more precise study, and the longer line means the uncertainty is there.
Yes.
And then there is a square, which is the point estimate. The
Okay.
size of the square reflects the weight of the study.
Yes.
And
So
then
means
there
it means that if the box is of the square is more big, so it is having
larger
more
study, more number of
weightage.
population. Yes.
Yes. And what about the right side? You have the weight
In
and
the right side, we have the weight, which shows the contribution of each study. In the right side, we have a numerical effect estimate where we can take any risk ratio, odds ratio, or hazard ratio.
okay. And what about the weight?
Sorry, sir.
What do you mean by the weight of the study?
Weight
Has it
shows
got
the
yes?
relative contribution of each study to our the meta-analysis, sir.
Okay. And what about the diamond and the graphical part in the below?
The diamond is the pooled estimate, sir.
Okay, it's the overall estimate of the study.
Overall estimate of the studies, and there is a one vertical line is the line of no effect,
Oh, effect.
and
Okay.
then in the bottom of the graph there is a heterogeneity statistic test.
Okay. And what if when you can see the diamond? What does the width of the diamond represent?
The width of the diamond is the confidence interval of the pooled effect.
Okay. Very good. Moving ahead. What is this image depict?
This is a funnel plot, sir.
Okay. What is its importance, significance in oncology or in a
It
study?
is used to detect the publication bias, sir. So the
Okay.
blue dots are here the study.
Okay.
If it is symmetrically distributed, that there is that means there is no bias. And if it's a
Mm.
asymmetrical distribution is there it means there is a presence of bias.
Okay. So this is a funnel plot. Okay. Which is
Yes, sir.
basically used in the meta-analysis to detect if there is any publication bias. Okay. The individual study is represented by the dots. Okay. So if you have even number of dots on either side of midline, it is symmetrical distributed. Means there is no publication bias. Okay.
Yes, sir.
But if the dots or the studies are confined to on either side of the midline, means more number of studies are on the one side of midline, it is asymmetrical distributed. So it is called then it
Presence is
depends that
bias.
it is bias. Okay.
Yes.
So what is type 1 error?
Type 1 error is rejecting a null hypothesis when it is actually true.
So it also called as false positive.
False positive, yes, sir.
What about type 2 error?
And type 2 is failure to reject a null hypothesis when it is actually false. That means false negative.
Okay. So what is the level of evidence in a clinical research?
Level of evidence is a hierarchical system that helps us to make the evidence-based decision. It is a grade the strength and the reliability of the scientific research based on the study design and the quality.
Okay. So can you say which is the highest level of evidence and which is the lowest level of evidence?
Level 1 is a meta-analysis, sir, followed by the randomized control trial, then case control at cohort study, and then case series, and last is expert opinion.
Okay. So in the level 1, that is the highest level, we have not only meta-analysis but also systematic review. Okay.
Okay, sir. Yes.
And for the second tier, we have the randomized control trials of all the cohort and case control studies. Then we have the individual case control cohort studies. Okay. Then we have
Yes,
in the fourth, we have the case series, and the lowest level of evidence is the expert opinion or case
expert
reports.
opinion.
Okay. So define interim analysis.
Interim analysis is the analysis which was done before the trial is completed at a specific point of time.
Okay. So when we are going ahead with a study or trial, if we have a pre-specified time point, means prior to completion of the trial, if we are doing an analysis, it is called interim analysis. Means prior to total completion of trial, if we are doing an analysis, but that is pre-specified with the pre-specified prior to starting the trial. So it's called interim analysis. So what is definitive analysis?
Definitive analysis was done after the trial is completed.
Okay. So after the final completion of trial, if the analysis is done, it's called definitive analysis. What about the secondary analysis?
Secondary analysis is done. It's the analysis of the secondary endpoints which are not in the primary focus of our study but can influence the final outcome.
No, it doesn't influence the final outcome. The thing is that the secondary analysis is not our primary focus in the trial. Okay, the primary focus is the primary endpoints. Okay, like disease-free survival, overall survival, or progressive survival. But in addition to the primary analysis, if we are going ahead with some additional insights or additional testing we are doing, which is not intended in the primary study, this is called secondary analysis, like quality of life or any relations with the biomarker. Okay.
Okay.
Okay. So, what is intention to treat analysis?
Intention to treat analysis is that all the participants that are randomized at the start of the study will be calculated regardless if they have completed the treatment or not.
Okay. So, in the intention to treat analysis, all the participants who have been included in the trial as at the trial for the initial trial, their data will be used for analysis, irrespective of whether they have completed the trial or not. If they have completed the trial and we're including them in the analysis, it is called intention to treat analysis. Okay.
Yes. Yes.
Okay. Then what is per protocol analysis?
Per protocol analysis includes only those participants who have completed the trial.
Okay. So we are accepting or we are rejecting the patients or the participants who have not completed the trial as per protocol. Okay.
Yes,
We are including only the participants who have completed the treatment as per the protocol.
Yes.
Okay. So what is the significance of this per protocol analysis?
Per protocol analysis shows the true efficacy of the intervention.
Yes. And what about the significance of intention to treat analysis? Why are you doing it? Even
Intention
if some
to treat
patients
analysis
have
shows the real world effect, real world scenarios.
Yes. It maintains the benefit of randomization and sources the real world scenario data, because in the real world we can have some patients who might not complete the treatment protocol. Okay.
Yes.
Okay. So next, what is blinding in a clinical trial?
Blinding is means the concealing the treatment allocation from one or more groups that are involved in the study or trial.
Okay. So how many parties are there in the
Mainly
trial?
three parties are there.
Yes. Can you name them?
A patient, investigator, and the analyst.
Data analyst. Okay.
Data analyst.
So why is blinding important? Is it important?
Blinding is important to minimize the bias.
Yes, blinding is important because it will remove the bias. So, can you define single blind, double blind, and triple blind? As you said that there are three parties. So there is okay. Go ahead.
Single blind means there is the patient is blinded. Double blind means both the patient and the investigator are blinded, and the
Yes.
triple blind where all the three persons are blinded.
Okay, very good. Now, as you can see here in the upper figure, this is a single blinding in which the patients or participants are blinded, and the double blind, both the participant and researchers have blinded, and in triple blind, all the three parties are blinded. Okay.
Yes.
Next question, define overall survival.
Overall survival is the time between from the randomization to the death of the patient from any cause.
Okay. So what is DFS or disease-free survival?
DFS is when the time from the completion of the treatment to the recurrence or progression or death.
Okay. What about progression-free survival?
PFS is the time from randomization to the disease progression.
Okay. So is there a difference between DFS and PFS?
DFS is calculated after the treatment is completed, and PFS is calculated from the time of the randomization.
Yes, actually the thing is that the DFS is calculated in the curative setting or adjuvant setting prior to completion of surgery or prior to completion of the whole surgery, chemo and RT. Then we calculate the disease-free survival, disease-free interval prior to from the end of the treatment to progression of disease or death of the patient. Okay. In progressive survival, what we do is that we calculate the time interval from the initiation of the treatment allocation to the progression of disease in metastatic setting. So in DFS is used in case of adjuvant or curative setting. PFS is calculated in case of metastatic setting. Okay.
Yes. Yes.
Okay. What is objective response rate?
This is a sum of the total complete response and the partial response.
Okay. What about disease control rate?
It includes the complete response, partial response, and the stable disease.
Okay. Okay. What is RECIST?
Response evaluation criteria in solid tumors.
Okay. So what is it based on? How do you count? How do you calculate this RECIST criteria? On which basis?
It is calculated from the CT or MRI available, sir. The size of the target lesion.
Okay. Based on the changes in the size of target lesion.
Yes.
Okay. Sum of the largest diameters. You take the sum of largest diameters and you calculate it. So
yes.
do you know any categories? How many categories are there in the RECIST criteria?
There are mainly 4 categories, sir. One is complete. First is complete response, where there is a disappearance of all lesion. Then is partial response, where there is more than equal to 30% decrease in largest sum of the largest diameter of target lesion. And then is stable disease, which is neither CR or PD. And then there is a progressive disease when there is more than 20% increase in sum of the largest diameter, or there is an appearance of new lesion.
Okay. So you have said about the RECIST and the categories. So do you know whether what is the difference between the RECIST 1.0 and 1.1? Do you have any idea?
In the RECIST 1.1, there is the lymph node is not included in the RECIST 1.0, sir. And also the measurement of the lesion, like in RECIST 1.0, the clinical diameter was 20 mm and the radiological diameter was 10 mm. But here in the RECIST 1.1, both have taken as 10 mm.
Okay. So can you name the target lesions? How many target lesions are taken into account in RECIST and RECIST 1.1?
RECIST 1.1, 2 lesions, 5 lesions were taken.
Okay, yeah. In the RECIST 1.0, total
10 lesions.
10 target lesions are taken into consideration and 5 per organ. Maximum 5 per organ.
Yes.
Okay. In RECIST 1.1, you take into account 5 lesions. Okay, maximum 2 lesions per organ.
2 per organ. Yes.
Okay, okay. And what about persist?
Persist was done mainly the PET from the PET CT. It's a PET response criteria in solid tumors.
Okay. Do you know any response evaluation criteria in brain tumors or neuro-oncology?
RANO criteria.
Okay, it's response assessment in neuro-oncology. And what about GIST, gastrointestinal stromal tumors?
CHOI criteria. Choi
Koi
criteria.
yes, koi criteria.
अच्छा.
Okay. Now I think we have concluded the biostatistics part. We'll be adding some questions on palliative oncology. So define pain.
Pain is an unpleasant sensory and emotional experience that is associated with tissue damage.
Okay. So while defining pain, you need to mention the name of the association which has given this definition. Okay. So it is given as per the International Association for Study of Pain, IASP. Okay. Hello. Am I audible?
Yes, sir.
Okay. So can you name the types of pain?
There may be two types of pain. Sir. One is nociceptive pain and other is neuropathic pain.
Dr. Ankita, you are not audible clearly.
Nociceptive pain. Hello.
Hello.
Yes, sir.
I think so there is some issue with the network.
Hello.
Hello. Hello. Hello. Hello.
Hello, sir.
Yes, yes, you are audible now.
Yes.
Okay. So we can continue now.
Yes, sir. Yes.
Okay. So what are the types of pain?
Sir, one is nociceptive pain and other is neuropathic pain. Nociceptive pain is when the pain is resulting from a stimulation of peripheral nerve endings, that is nociceptive pain, and the neuropathic pain is due to the injury to the nerve. It can be due to the it can be any compression or trauma.
Okay. So you can clearly describe can you describe the WHO analytic ladder steps?
So there are mainly three steps, sir. First is step 1, which is for mild pain, where we give non-opioids like paracetamol or NSAIDs. So if the pain is not controlled by non-opioids, we move to the second step where we add the weak opioids with the non-opioids. And for the weak opioids, we can add the tramadol or codeine. And if the pain is still not controlled, then we move to the step 3, which is severe pain, where we add the strong opioids along with the non-opioid. And in the strong opioids, we can give the morphine.
Okay. So can you name some additional or adjuvant analgesics or adjuvant drugs that are added to the step 3 in step 3?
Adjuvant, we can add as sir, corticosteroids, antiemetic, and some muscle relaxant and anticonvulsant.
Okay. So we can add some co-analgesics or adjuvant to the step 3 severe pain. If there's edema, we can add corticosteroids. In case of if there's neuropathic pain and the antidepressant. Okay. For muscle cramps, we can add muscle relaxants. For any colicky pain, antispasmodic. Okay.
Yes.
And if there is any vomiting or nausea, you can add antiemetics. Okay.
Yes.
So regarding you can see the drug that is morphine. So what type of opioid is it?
Strong opioid.
Strong opioid. So what will be your starting dose in case of morphine? How do you start the dosing in case of morphine?
So we can give a tablet form or in the IV form. So based on the pain, and if for the tablet form there is immediate release morphine and there is sustained release morphine. For the immediate release, we can start from 5 to 10 mg every 4 hourly. And for the sustained release, we can give a 15 mg tablet every 12 hours for the longer action. And for the IV dose, we can start with 2 to 5 mg of morphine every 4 hourly.
Okay. So you have rightly said it is available in two form, basically not oral form and also IV form. But basically in the starting criteria, we use the immediate release form oral tablet, and depending upon the intensity, we can go ahead with 5 to 10 milligram, which is given every 4 hourly. So for 6 times we'll be giving, but in order to avoid the night dose, as the patient will be asleep, so we can add 2 doses of morphine in the time before going to bed. Okay, and once the pain is established, we can switch over to sustained release morphine. Okay,
Yes.
and if the patient is not tolerating the oral morphine, we can switch over to IV morphine.
Yes.
Okay. Can you name some potential side effects of morphine?
The most common side effects are constipation, nausea, vomiting, drowsiness, and there could be a respiratory depression also.
Okay. So, any drugs that is given in prophylactic setting along with morphine? Can you name some drugs?
We could add some laxative for the constipation and some antiemetics for the nausea and vomiting.
Yes. For the antiemetics, we add metoclopramide or ondansetron, and for constipation, we add laxatives. Okay.
Yes.
If you're suspecting respiratory depression and if patient is very severe respiratory depression, what is the antidote?
IV naloxone.
Okay. Coming to this image, can you describe this image?
This is a buprenorphine transdermal patch.
Okay. So when do we consider this patch in case of pain management?
When patient presents with moderate to severe pain, which is not controlled by the opioids, tablet opioids, or if patient is present with a renal dysfunction where we could not give the analgesics for a longer period of time, and when the
Yes.
if there is a pain is not controlled from the tablet analgesics, then we can give the patch form.
Okay. So in case of moderate to severe pain, when the pain is not controlled with oral morphine or oral opioids, then we can switch over to transdermal patch. And this is even important thing is that you need to remember that in case of renal dysfunction, we can use the transdermal patch, buprenorphine patch. Okay.
Yes.
Also, we can use the fentanyl patch.
Yes, sir.
Right.
Yes,
If
sir.
there is a history of any opioid misuse, we can use this transdermal patch.
Okay, sir.
Okay. And what is the typical duration of treatment? Means days after which you need to change this patch for buprenorphine and for
buprenorphine,
fentanyl.
it is 7 days for
Yes.
buprenorphine, and
And
for fentanyl, it is 72 hours.
Okay. This is probably the last question of today's session. So, what does this image depict?
These are the location that we commonly apply the patch, sir, transdermal patch.
Okay. So, what are the possible sites? Can you name the possible sites as depicted in this figure?
The first is the upper outer arm, then upper chest, then third picture is back, and the fourth is side of the chest.
So there are basically 8 locations.
8
4
locations. Yes.
Okay. Okay. Now I think we have come to the end of this today's session. Thank you, Dr. Ankita.
Thank you, sir.
So do you have any questions? Actually, it was in PPT form, so I could not see the questions.
Hello, sir. Can you explain p-value again, sir?
Okay. What do you actually want to know about p-value?
The cutoff for significance.
Okay, so you might be knowing that p-value, the cutoff significance is usually basically is used as less than 0.05. Okay, and if the confidence interval is less than 1, it is considered significant. Anything else?
Thank you, sir.
Okay. You need to you needed to know about the forest plot. Okay. Okay. Give me one time. Sometime I'll be sharing the slide again. So is this slide visible? Hello? Am I audible?
Yes, sir, visible.
Okay. So you needed to know about the forest plot. So this is the forest plot, which is basically used in case of meta-analysis. Okay. So you'll be asked that identify this image. This is the forest plot, basically used in meta-analysis. On the left-hand side, as you can see, is written the study. Okay. Under study, you have the different trials. For example, Wong et al. At 2024. So Wong is the name of the PI or the first author who has done the trial, and 2004 denotes the year of publication of trial. So you have the individual studies on the left hand side. Okay. And the middle side, you can see the under risk ratio, it's the graphical representation of the total forest plot. Okay. Am I audible?
Yes, sir.
Okay. So in the midline, you have the you have the graphical representation of this forest plot, and there is a straight line in the middle going from up to down. It is the line of null effect. Okay. And the individuals, this, I think the pen is visible.
Yes, sir.
Yes, sir.
Okay.
Yes.
Yes. So this is the line of null effect, straight line. Okay. And this is the this individual study is represented here. As you can see, this is an study. This is another study. So these are extending from this. There is a square in the middle, and there are both on the both the sides. Both the sides denotes the like the in the box and whisker represents this represents the confidence interval of the individual study, and the box represents the square. This square represents the weight of the study. Okay, this is the individual study, and if the this individual study is crossing the line of null effect or line of line 0, that is line of null effect, or line 1, so it is not significant. It is not favoring the trial or not against the trial. So this line of this is line of no significance. Okay. Okay, and on the right hand side you have the weight. That is the depicts the individual weightage that the individual trials has got in this meta-analysis. And this on the right side we have the risk ratio and odds ratio. This is the value, and this is represents the 95% confidence interval. On the below side we have got the diamond, which represents the overall effect of the study. Okay, the end of the diamond represents the confidence interval of the overall study. Okay, and on the bottom side you have the heterogeneity. How heterogeneous is the test? It is depicted by this chi-square and p-value. We did not go details into this test, but you will be used to identify this test, or you can be asked the what is this confidence interval, what is the weight of the study, what does square represent. These may be asked to you. Okay, I think I am clear. Hello. I think we have completed the day 3 of session, day three of this Mpro 2025 webinar. Thank you all for joining in great numbers. We appreciate your valuable time, and please log on tomorrow at 7 p.m. for the day 4 session. Okay, thank you all. We'll wind up here.
Sir, hello, sir. Hello, sir.
Yes.
Sir, like last time for CA breast case presentation, there was a transcription of what the examiner asked the question and what the candidate answered back. Can we get the transcript again, sir? Like previously we had for CA breast in the
Sorry,
group.
I couldn't get you.
Sir, in the group, Kanu sir has shared a document where there was a transcript of the case presentation which happened yesterday in CA Press, where Senapati sir was asking the questions and the candidate was answering that exact question and answer was in a document. Can we get the same for today's case also, sir?
Yes, yes. We'll be sharing it tomorrow.
Okay, sir. Thank you, sir.
Okay. Thank you all. Good night.
Hello, can I end the session here? So thank you so much everyone for giving us the opportunity to host the session, and with everyone's permission, I'm closing the session over here for today. Good night to all of you.